Okay, cleared the memory, we're good. Is she in any current pain? Quality, duration, location, where does the pain radiate? Gradual pain or sudden onset? Has she ever had this pain before? If so, when? Does it occur regularly? Sporadic or is it constant? Determine if there are any vaginal bleeding or spotting. The amount of bleeding and how long did it last? What's the color of the blood? How many pads? Did the bleeding stop? Were there any clots, tissues? If so, try to get a sample and take it to the emergency department. Okay, so save a sample. Any other vaginal discharge, color, duration of discharge, and we want to identify any disagreeable odor. Determine if the woman's bladder has broken. Does she need to move her bowels or push? If she thinks that she has to move her bowels, that's a baby. This indicates that the head is in the vagina and it's pressing against the rectum. Delivery is imminent. Do not let her go to the toilet. She's going to drop a baby in there. What are the What are the contractions like? Important to distinguish false labor, Braxton Hickson's versus actual labor. True labor pains are. Is this on? Okay, I'm green. Are how frequently are the contractions? So if they are, I skipped one. True labor pains are regularly spaced and increase in intensity. So it starts low and then gets better, gets worse, gets more intense. So how frequently are the contractions? If they're more than 5 minutes apart, then there's usually time to get to the hospital. If they're 2 minutes apart, baby's coming. We gotta give birth. Usually in a multipara. Delivery is imminent, especially, so if she's been pregnant before, yeah, that baby's on its way. Inspect the woman for crowning, indicates that the baby will be born within the next few minutes. During our secondary assessment, we're gonna base it on the physical exam chief complaint. A pregnant woman may present with a different problem other than the pregnancy. Regardless of the chief complaint, the full body exam should include fetal heart tones and rate. Palpate fetal position. Ask the last time that the woman felt the baby move and if there was change in the amount of movement. Monitor vital signs for both patients. Ask her to describe any pain to help determine if she is having contractions. Inspect the vaginal area for crowning, vaginal bleeding, or discharge. If there's crowning, delivery may occur on scene, and if there is no crowning, then how far apart are the contractions and the time of them? If there's bleeding or discharge, determine when it started and check for abdominal tenderness and rigidity. Assess serial vital signs to determine if the woman is or the fetus is in distress. If the water's broken, then we're going to ask about the color of the fluid. If it's brown or black or has a strong odor, it may have meconium staining. The fetus may aspirate meconium into its lungs, which could result into life-threatening sepsis. It's very bad. If delivery is imminent, you will not have time for extensive physical examination. We're going to assess the woman's vital signs. If the woman's blood pressure is elevated or she is showing any signs of edema, test the deep tendon reflexes in the knee for hyperactivity. And we're also going to look for elevated blood pressure, facial edema, swelling in the face, fluids in there. Hyperactive reflexes are strongly suggestive of pre-eclampsia. We're going to prepare for seizures before, during, or after delivery at this point. So we're going to estimate the gestational age, palpate the abdomen for its height of the uterus by finding the fundus just above the symphysis pubis, gestational age 12 to 16 weeks. Level of the woman's umbilicus, gestational age 22 weeks, and reaching to the xiphoid process at or near term. So if you are at term, your fundus is right at your xiphoid process, but don't break the xiphoid bone. Listen for fetal heart tones. Fetal distress is indicated by anything lower than 120 beats per minute. To measure the fetal heart rates, we're going to do the following. So we're going to listen with the stethoscope at the 4 o'clock position of the woman's abdomen. So if you're looking at me here, yeah. So we're going to listen with a stethoscope here to listen to fetal tones. About 2 inches from the umbilicus. Where's the umbilicus? It is, what's your belly button? Okay. Palpate the woman's pulse at the same time. So we're going to feel the carotid while we're also listening to the fetal heart rate down here where the baby's at. If it's the same, the stethoscope is likely picking up an echo of the mother's pulse rather than the fetal heart rate. So it should be different. Did I go through all those? Yeah. If there's ample time to reach the hospital, do the following. Place the woman in the lateral recumbent position. Remove any underclothing that might obstruct delivery and begin transport. Lateral recumbent. I'm pretty sure that's stirrups. You're laying down, recumbent. I gotta look that up again. If there's not time to reach the hospital, prepare for delivery on scene. Try to find a private and clean area. Keep nervous bystanders busy, preferably elsewhere. Be calm and professional. Give bystanders a puzzle. Reassessment. Perform an ongoing examination. Include an assessment of the woman's serial vital signs, fetal heart rates, heart tones, time, contraction. Perform a full body exam and check interventions and transport. If delivery is imminent, notify staff at the hospital. Provide an update on both the mother and the newborn status after delivery. If the delivery does not occur within 30 minutes or complications occur that cannot be treated in the field, notify staff. Provide rapid transport. If a pregnant patient has a complaint related to childbirth, include the pregnancy status in the radio report. Pathophysiology and management of complications related to the pregnancy. So substance abuse. Illicit drugs used by the drug-addicted woman, pregnant woman, pass through the placenta barrier and enter the fetal circulation, causing the fetus to develop birth defects and become addicted. The not so PC term, crack baby. Woman does crack, baby likes crack. Very sad. The fetus can have withdrawal signs after it's born, so it could have respiratory depression, could have bradycardia, tachycardia, could have seizures, cardiac arrest. Treatment should concentrate on cardiorespiratory support. That was a test question actually. We were talking about how much Narcan you give a baby, how much naloxone, which would reverse narcotic effects. Supine hypotensive syndrome. An enlarged uterus can compress the inferior vena cava, may diminish the or occlude venous blood return in the heart, and mainly occurs when the pregnant patient is supine, but also when sitting. Usually seen in the third trimester when the uterus is so much larger and the patient mobility is impaired. Most prone during labor, but also in sleep states. Supine hypotensive syndrome can result in significant maternal hypotension and fetal distress. Takes 3 to 7 minutes of compressions before signs and symptoms shows. So you could have nausea, could have dizziness, tachycardia, speedy heart rate, claustrophobia. Later signs, breathing difficulty. You could actually pass out, have syncopal episodes. Your heart's not getting enough blood. Back to it. Management includes placing the patient on the left lateral recumbent position. So keep everything's on the, just keep pushing her, put her on the left. You know what, whenever you're transporting, just go ahead and tell her to lay on the left. Treatment of underlying causes. So we want to see what else she could be doing or using. Monitor blood pressure, vital signs, and obtain an ECG electrocardiogram. We're going to determine cardiac conditions. So when obtaining medical history for the pregnant patient, determine the nature and treatment of any heart condition. Cardiac medications, we're going to be diagnosed with dysrhythmias or heart murmurs. History of rheumatic fever. Born with congenital heart defects, could also be benign unless until the added stress of the pregnancy. So episodes of dizziness, lightheadedness, syncopal episodes with pregnancy could also occur. Maybe signs of dysrhythmias that could be dangerous during labor. Peripartum cardiomyopathy is an uncommon form of heart failures that happens during the last month of pregnancy or up to 5 months after giving birth. Risk factors of peripartum cardiomyopathy: obesity, history of cardiac disorders such as myocarditis, death of heart tissue. That's something COVID vaccination causes. Use of certain medications, smoking, alcoholism, multiple pregnancies, African American descent, poor nourishment. Could be easily confused with eclampsia. Must test for proteinuria, which is impossible in the field. So if there's protein in the urine, I mean, honestly, well, an obvious sign if they're peeing and the bubbles show up. There you go, proteinuria. Proteinuria. I have that because I have kidney disease. Hypertensive disorder. Major cause of mortality and morbidity in pregnant women. Previous hypertension or borderline hypertension may be exacerbated by pregnancy. So chronic hypertension, blood pressure equal to or greater than 140 90 millimeters Hg. That's a very specific number. Chronic hypertension, blood pressure equal to or greater than. Okay. Exists prior to pregnancy, occurs before the 20th week of pregnancy, or persists postpartum. Carries an increased risk for stroke or other cardiovascular problems. Gestational hypertension, formerly known as pregnancy-induced hypertension. So this develops around 20th week of pregnancy and resolves spontaneously at postpartum. Risk includes obesity, glucose intolerance, and maybe an early sign of preeclampsia. We're going to go into preeclampsia. Preeclampsia occurs in about 8% of all pregnancies. Risk factors. First pregnancy before the age of 20 years is the highest risk factor. Advanced maternal age. History of multiple pregnancies, chronic hypertension, renal disease, diabetes, being African American. Preeclampsia manifests after the 20th week with a triad of symptoms, including edema, usually the face, ankle, and hands. Gradual onset hypertension, protein in urine. Other symptoms include severe headache, nausea, vomiting, agitation, rapid weight gain, and visual disturbances. The woman may require emergency hypertensive medication, which we do carry, such as labetalol. What's the name for this? Trandate, normodine is labetalol. Labetalol decreases blood pressure. Yeah, labetalol decreases blood pressure, but we never want to decrease blood pressure more than 10%. Hydralazine, alazine, or aprosolene. I have no idea what this is. The other condition that may accompany preeclampsia includes liver or renal failure, cerebral hemorrhage, abruptio placenta, HELLP syndrome, hemolysis, elevated liver enzyme, low platelets. Interesting. So these are all the conditions that accompany preeclampsia: liver renal failure, cerebral hemorrhage, abruptio placenta, or hemolysis, elevated liver enzyme, low platelets. Treatment in the field is limited to treating the presence of preeclampsia and or eclampsia with rapid transport to a medical facility. Is this mixed up? Okay, this is all pre-eclampsia. Seizures. Seizures can be caused by hypertension, toxemia, preeclampsia, pre-existing seizure disorder. Treatment is difficult because drugs normally used for seizures cause fetal distress. So magnesium sulfate is used for seizures, and we will give, so there's 2 hearts. You want to give 2 milligrams of mag sulfate per heart, so 4 milligrams for a pregnant patient. Magnesium sulfate is recommended treatment, especially with eclampsia. High flow supplemental oxygen is needed to counteract hypoxia. Potential complications may include abruptio placenta, hemorrhage, disseminated intravascular coagulation, and death. Diabetes, gestational diabetes mellitus, is the inability to process carbohydrates during pregnancy. Increased maternal insulin production causes an imbalance between glucose production and insulin supply. The patient may be asymptomatic, they might not have symptoms, or may exhibit the same signs and symptoms as the diabetes mellitus. So they could have polyuria, polydipsia, polyphagia. They might have to pee a lot, they might be really thirsty. I forget what polyphagia is. They might speak in tongues. They might pass out. I don't know. Treatment consists of diet control, oral hypoglycemic medication. Diabetes may be significantly affected by pregnancy. Wildly fluctuating. This is record. Okay, I can't see myself. Shoot. I want to make sure I don't run out of memory. Cool. Diabetes may significantly affect pregnancy, so wildly fluctuating blood glucose levels may manifest as either hypoglycemic or hyperglycemic. So you could have one or the other. Because hypoglycemia agents may affect the fetus, insulin-dependent diabetics may need to adjust dosages during pregnancy, just like anything else. You know your body more than anybody else. Pregnant patients with a history of diabetes should have blood glucose levels that test with a glucometer. Pre-hospital management includes high flow oxygen, IV fluids. We're going to give IV fluids if they're hyperglycemic. Administration of D50W with a low glucose reading, so dextrose. Oxygen and IV fluid therapy per protocol for patients who are hyperglycemic. Respiratory disorders. Shortness of breath or general dyspnea is the most common complaint of pregnant patient, often caused by hormone-related anatomic changes to the respiratory system. Generally, it's a minor concern, possibly an underlying condition that is aggravated by the pregnancy. Asthma is a common condition that complicates the pregnancy, and it may be a pre-existing illness or occur for the first time during pregnancy. Acute attacks may lead to progressive hypoxia for both the woman and the fetus. Maternal complications of an asthma attack may include premature labor, preeclampsia, respiratory failure, vaginal hemorrhage, heat eclampsia, and fetal complications could also include premature birth, low birth rate, growth retardation, and fetal death. Hyperemesis gravidarum, a condition that persists, nausea and vomiting during pregnancy. It is much more serious than morning sickness, and especially during the first several weeks. Hyperemesis gravidarum. So emesis, vomit, hyper, a lot. Condition persisting of nausea and vomiting during pregnancy. Prolonged vomiting leads to dehydration, malnutrition. The exact cause is unknown, but is possibly from stress, gastrointestinal system changes, increased hormone, estrogen, human chorionic gonadotropin, that one. It is common in first-time pregnancies, multiple gestations, obese women, and symptoms include severe persistent vomiting more than 3 or 4 times daily. Projectile vomiting, consisting of bile and sometimes blood. Severe nausea, pallor, jaundice. Pallor, whiteness of the skin, probably from dehydration, jaundice, yellowing. Pre-hospital treatments include checking the blood glucose level, starting in IV line, normal saline, administration of the first 250 milliliters of fluid, and administering diphenhydramine if protocols allow, which is the same thing as Benadryl. 10 to 50 milligrams IV, deeply intramuscular. What are we doing this for? Treatment, what are we treating? Oh, yeah, emesis. Contraindications if the patient is taking monoamine oxidase inhibitors. Administering adenosine, Zofran by IV or the mouth if protocol allows it. That is our antiemetic. And checking for orthostatic vitals and obtaining an electrocardiogram. Transporting to the hospital. Renal disorder. During pregnancy, a woman's kidneys increase in length and ureters get longer, wider, and more curved. It changes increase the capacity, but also can lead to urinary stasis, urinary tract infection, may be mild, may progress to states leading to low fetal birth weight and retarded fetal development. Can we even say that? Premature labor, I've never heard that word, intrauterine fetal death. The enlarging of the uterus puts pressure on the bladder, causing an increased urinary frequency. If the patient has a pre-existing renal disease, she may experience compounding of problems. If there is no pre-existing renal disease, then the patient may develop renal malfunction or failure from hypertensive disorders or other conditions. Rh sensitization, so this is your blood type, A, B, positive, O positive, O negative, all that. Rh factor is a protein found on the red blood cell for most people. If the factor is absent, the person is Rh negative. If the mother is Rh negative and the father is Rh positive, fetus may inherit this factor. The fetal blood can enter the woman's circulatory and produce maternal antibodies to the factor. It is not normally a problem in first pregnancies, but subsequent pregnancies, the antibodies will attack the fetal red blood cell because it is seen as foreign proteins. It can cause death of the fetus. Hemolytic disease, erythroblastosis fetalis, hemolytic disease of the newborn presenting with jaundice, anemia, hepatomegaly, I guess. Okay, so basically, if the mother's RH is negative and the father's RH is positive. So if you're out there on Tinder, if you're out there on, you know what, I'm actually going to put this, on your dating page, you should totally put whether you're like positive or negative. Maybe not, maybe it's controversial, but if you want to give your future child the best chance, just saying, make sure that you're both positive or both negative. Early pregnancy infections can affect the organ system. Later pregnancy infections can cause neurologic impairments, growth disturbances, heart and respiratory conditions. Most commonly encountered infections include the varicella-zoster virus, human paravirus, B19, fifth disease, toxoplasmosis, cytomegalovirus, urinary tract infections, group B, streptococcus, GBS, leading to life-threatening infections in newborns caused by Streptococcus algalecticai, which lives in the genitourinary and gastrointestinal tract of healthy people. The bacteria can proliferate during pregnancy, resulting in urinary tract infection, uterus infection, stillbirth, and if it is passed to newborns, it can cause respiratory problems, pneumonia, septic shock, meningitis as well. I kind of want to look at the beginning of these. Okay, so viruses and parasitic infections. So infection can affect the organ system later in pregnancy. You could get neurological impairments, growth disturbances, and the most encountered infections are the varicella-zoster virus, the human paravirus, B19, toxoplasmosis, cytomegalovirus, urinary tract, group V, streptococcus caused by Streptococcus algalecticai. Hopefully I remember all those. Human immunodeficiency virus, HIV. Pregnant women may infect the infant during the birthing process, and an HIV-positive woman can take medication to control the infection. Cholestasis. Cholestasis is a disease of the liver that can occur during, what time is it? 6:40. Can occur during pregnancy. Hormones slow down or block the normal bile flow of the liver. If the bile cannot flow normally, it builds up in the liver and spills into the bloodstream. Symptoms include profuse, painful itching, particularly in the hands and feet, most common. Fatigue, depression, nausea, right upper quadrant pain, color changes, waste elimination, dark urine, abnormally colored stool. Cholecystasis. Hormone slowdown. Profuse, painful itching. Hands and feet. Interesting. High risk includes carrying multiple fetuses, a familial history of cholestasis, previous liver damage. Cholestasis is relatively benign and transitory for the woman, but can be serious for the fetus. Complication includes preterm birth and stillbirth. Torch system. Toxoplasmosis and other agents of rubella, cytomegalovirus, herpes simplex. This refers to infection that is passed through the placenta from the woman to the fetus. Neonates show similar symptoms for any of the 5 infections. So you have cytomegalovirus, CMV, is a member of the herpes virus family. There is no known cure. CMV can remain dominant in the body for years. In active stages, CMV can include headache, chills, malaise, prolonged high fever, extreme fatigue, enlarged spleen. Pregnant women have an increased risk for active infection and more serious infections. So the newborn with CMV are susceptible to lung problems, blood problems, liver problems, swollen glands, and rash, and poor weight gain. Pathophysiology, abortion. Abortion is defined as expulsion of the fetus from any cause before the 20th week of gestation. Most occur during the first trimester when the placenta is matured. It is broadly classified as spontaneous abortion, miscarriage, and occurs naturally. Cause include acute chronic illness in the pregnant woman, maternal exposure to toxic substances, fetal abnormalities, abnormal attachment to the placenta, elective intentional abortion. While taking a medical history, the paramedic must be professional and dispassionate despite the personal convictions. The pregnant patient presenting with vaginal bleeding or abdominal pain should be transported to and evaluated by the physician. Habitual abortions are defined as 3 or more consecutive pregnancies that end in miscarriage. Caused include chromosomal and endocrine disorders, ovarian issues, uterine malformations, cervical conditions, infections, lifestyle factors. I'm still recording. 25 minutes. All right, I've been going for a minute. A threatened abortion is an abortion attempting to take place. If it is characterized by vaginal bleeding in the first half of the pregnancy, usually by the first trimester, it is rarely severe pain because uterine contractions are not rhythmic. It can progress into an incomplete abortion or may subside. Treatment is usually complete bed rest or conditions that may be monitored. So the pre-hospital role is transport and support. An imminent abortion is a spontaneous abortion that cannot be prevented. Signs and symptoms include severe abdominal pain, strong uterine contractions, vaginal bleeding, often massive, cervical dilation. And pre-hospital goals include maintain blood pressure and prevent hypovolemia. Treatments include establishing IV line and normal saline to maintain blood pressure, administering 100% of supplemental oxygen via non-rebreather mask, 15 liters per minute, and obtaining an electrocardiogram. Proving emotional support with rapid transport and watching signs of shock. Where are we at? Incomplete abortion is whenever parts and products of conception remain in the uterus. Example is the fetus is expelled but the placenta remains. Vaginal bleeding will be continuous. Watch for signs and symptoms of shock. Start an IV line of normal saline to keep that BP up. And consult with medical control if the products of conception are protruding from the vagina. Collect all products of conception and give to the receiving facility, and allow the patient to view the fetus if she wishes, and be prepared for strong emotions. A complete abortion is when all the products of conception are expelled. Missed abortion occurs when the fetus dies during the 20th week of gestation, but remains in utero. Field management consists of emotional support and providing transport. The hospital manages consists of dilation and curettage, D&C. Suspect a missed abortion if the patient has a history of threatened abortion with cessation of vaginal bleeding and gradual diminished signs of pregnancy. You will note the following on examination. The uterus will feel like a hard mass. Fetal heartbeat cannot be heard. A missed abortion is generally caused by maternal disease, abnormalities in the embryo, uterus, placenta, fetal chromosomes, and it is generally precedes a spontaneous abortion. In a septic abortion, the uterus becomes infected following the abortion. So the history will include fever, bad smelling vaginal discharge within a few hours after the abortion. And the physical examination shows that the fever and abdominal tenderness, The infection will progress into septicemia and septic shock in severe cases. Pre-hospital management include establishing IV lines, administering oxygen, EKG, rapid transport, and fluid administration for blood pressure. Third trimester bleeding. All right, let's pause.